that my good friend Joel Shu was really the person that organized this session, and due to some technical issues on his part, even though he was able to do his talk earlier a couple hours ago, he was having trouble getting into this. So it worked out good that he had asked me to be his co-chair, because I was not really prepared to do anything. But anyways, so here we are. And with that, I'm going to introduce Tom Ribeiro to talk about the prognostic value of AI-predicted ECG-Age. Go ahead, Tom.
So first of all, I would like to thank Bob. I think you need to close your microphone, otherwise we will listen some kind of echo. So it's a big pleasure to be here. It's my third time in this meeting, so I'm happy to present new data from our cohort, our study. And I'm Tom Ribeiro. I'm the past president of International Society of Electrocardiology, that is the sister society of ECG. And I'm based in South America, in Belo Horizonte. And probably I have shown this slide previously, in Minas Gerais, in the southeast of Brazil, not far from São Paulo and Rio. It's a state of mountains, colonial cities, very small municipalities. Peter McFarlane has been here 3 times now, and Belo Horizonte is a 5 million persons city in the center of the city. In my university is one of the top universities in Brazil. It's called UFMG, and I'm based in the University Hospital. We run this telehealth network of Minas Gerais. That it's a telehealth network with a focus in cardiology, and we now provide ECG, tele-ECG for something like 1,100 municipalities, and we have almost 2,000 points of care in the cities, in the spread in the northeast, center-west, and the Amazonian region in our country. We are performing 3,000 ECGs a day. We have more than 5 million ECGs performed, and we kept since the beginning the files, the original files, the data files. I'm a cardiologist. I'm not a data science or engineer, so please understand my talk with a different view, considering previous talks. So this service has 3 to 5 cardiologists on duty. They answer the urgent case in less than 10 minutes. They work 24 hours a day, 7 days a week. And then we developed a web-based management system that can facilitate a lot how the cardiologists give the report, and tomorrow it will be presented by a master student. What was the system we developed, and this database of ECGs was organized in the past, and I presented this 2 years ago to this same audience. Many of you were there. What we call the code study, that we try to get the tracings, the metadata, the clinical data, but also we linked this data set with the mortality database of the Brazilian government, and then we link it also with the hospitalization data set, and we did such a kind of electronic cohort, and we are trying to analyze its huge material and a lot of possibilities, and we have some results that we presented here in the past, and we're presenting some new results now. So this is now probably one of the largest data sets that have been using for AI. So this is a recent review from the Mayo Clinic team that published much more. And so our data set is mostly from primary healthcare units. It's a little different. So for some way, we do not have the hospital data. From the other side, we are much closer to the population, to the real prevalence of abnormalities and the situation that you have in the population. We are doing epidemiological studies, and this was Gabriela Miana, who presented some data here also in the Young Investigator Award 2 years ago, and showing that we can get established ECG abnormalities and try to understand what are the prognostic value of these abnormalities in the clinical practice in a community-based sample. And here showing that women has a worse prognosis with AF than men, but there are many other studies in this same type being done. And as Peter said, and he's a co-author here, we used this data set to try to apply DNN to the classification of ECG, and this paper was published last year in Nature Communications, but was available online since the previous year as a preprint. And so we got very good results. We have an ECG presented in this paper, only have examples of ECG, so it's not all AI ECG papers that do not have ECG tracing, some of them have, and showing, as many others, that the machine is more accurate in terms of F1 score, but also the precision is specificity below or at least equal than the residents of cardiology and internal medicine, and better than students in this set of data. So we are moving to other questions, and this one is something useful. Is AI predicted ECG-Age a potentially useful tool in the assessment of the risk of death in this general population of this primary healthcare group of patients that we have? And it's not a new question. We know people from a decade ago showing using not artificial intelligence, but mathematical and Bayesian methods, that when a patient has risk factors, the predicted heart age is higher. When you have a normal population, the ability to predict heart age is very good, but when they have risk factors for cardiovascular disease, or when they are diseased, they have a higher predicted age. And this is a paper that we found, but we are not aware of them before beginning to work with these. And when we are working in this question, we saw the Zakiatia paper in circulation arrhythmia in electrophysiology, showing what we are finding by this time, that is a good ability of the machine to predict the age, and that patients that with normal persons have a linear evolution of their ECG-Age, but when they have this kind of cardiovascular events, the ECG-Age increases a lot. So there's a relation with the risk factors in disease and the ECG-Age. Considering this, we developed, we used our data set, our database to train the CNN not to give us a diagnosis, but to give us the predicted age of the person of this ECG. Again, it was only the tracings. We didn't add any kind of additional data like sex, age itself, or comorbidities. The input of the system was only the ECG tracings, and we did as the standard. We divided the ECG data set in training and validating 85%, and 15% is testing data set. That was balanced data set. It was not completely handled here because we get a balanced data set for both the validating and the testing set. And we used the DNN, the convolutional neural network, similar to a residual network, to analyze the ECGs. They are standardized. They came from tracings from 300 to 1000 hertz, and they resampled for 400 hertz. They are the same size because some of them they have 7.2 seconds. One Brazilian company has this output, so we have to convert all this to a standard set of ECGs. And the model was validated in the 15% of the code cohort, but also in 2 external cohorts. The ELSA Brazil, it's an epidemiological study that it's 15,000 persons that have been followed now for 10 years. They are public servants from universities in 6 Brazilian capitals. I'm the PI of the ECG of this group, and also a Chagas disease cohort that it's less than 2,000 patients. So we, considering the mean average error, we got these 3 groups. One is if the difference between the predicted ECG, the predicted age and chronological age is more than 8 years, so the ECG is 8 years older than the person, seems to be older. It's one group. The other is between 8 minus and plus, and the other if TCG is predicted to have less than 8 years than the chronological age. And we did standard statistical methods like Cox regression models, and we did a lot of sensitivity studies in order to try to understand what's happening, how we can interpret these results, and we try to show some of them now. So we got figures that are not very different, and images that are not very different from the other authors, like Zaki. So the mean error of 8.4 years, and so there is a good ability in this large data set, it's the code, but also in the ELSA and the Summitropy, it retains this ability, although with some laws in the force of the correlation. When you see the samples, we are saying about the code, they have a 3 years of follow-up. The ELSA, they have a higher prevalence of risk factors, probably because it's an epidemiological study, much better quality of this data. In the code, these are self-reported risk factors. Here it was evaluated with exams, so it's much better. And in Summitropy, we have a shorter follow-up of only 2 years, and they are mostly Chagas cardiomyopathy patients, so they are with a different profile. So what we can see, if the ECG, if the ECG is 8 or more years older or greater than the chronological age in these 3 cohorts, we have a higher risk of death. And if the ECG is younger than the patient, if the ECG-Age is 8 or more years less than the chronological age, in the code, in the ELSA study, we have some kind of reduction of risk. And the Summitropy, that we very different cohort, this reduction is not clear. So when we run the Cox analysis, we can see that the increase of risk of having a ECG-Age more than 8 years older than the chronological age, it's of 80%. And that it's mostly maintained when you go to the risk factors in the code study. But when you go to ELSA, that you have a much better characterization of the risk factors, there is some loss of effect size when you go to this adjusted sample. And in the Summitropy, that's a cohort of Chagas cardiomyopathy mostly, we have a higher effect. The hazard ratio is 2.42, and it's not affected by the correction by factors that for coronary heart disease, they do not have any relation with the risk of death in Chagas disease. So we try to understand what's happening. We thought firstly that it was some kind of summary of ECG abnormalities. So we go, if we study only those with normal ECGs, and then we go only for code and ELSA because there is no many normal persons with the Chagas cardiomyopathy. And we thought that the prognostic value was retained, even when you adjust for the risk factors. And when you go to the ELSA, it lost the significance, but the size of effect is similar. And we understand that the sample is underpowered for this because we have only 19 deaths in this group. It's a much smaller sample. When you go to the measurements, we can see that they are not really different, though those normal ECGs, they were obtained by when the cardiologist that reported the ECG said it's normal, and also that the automatic software said it's normal. But you go to the measurements are very, very similar. And they are significantly higher, sometimes different in those with more than 8 years, but they are not really, really different. So does not seem to be some kind of measurable factor that can explain this difference. So we try to understand what is happening in terms of where this difference lies, where this information inside the ECG that gives information about the ECG age, that we understand that it's a marker of biological age, can be found. And we use this kind of salience maps that I'm a cardiologist and will not be very, very ready to explain, but showing that when you change the signal concerning the frequency component, most of the information is between 8 to 15 hertz. And when you go to medical doctors to try to classify correctly if the patients with the same age, if they have ECG predicted, AI predicted age higher than the others, they failed. They cannot. 3 cardiologists, myself and two fellows that are very experienced, we cannot say from persons with the same age which patient has an ECG age of more than high years than the chronological age. Then we go to the salience maps, and again showing ECGs, and they try to highlight where the machine can trying to see. It's not very easy, but again, we are surprised that the relatively low frequency components are more important than the high frequency components. So we do not know exactly what the machine is seeing, but we have some clues, and we understand it's a very important research field. So only to conclude, I have additional data to show if you need by the end, but the predicted ECG age may reflect biological age. It may be a promising tool for his prediction for overall mortality when combined with Framingham heart score, for example, or with other scores of risk. This is a relatively easy to obtain network because data is available everywhere. And there is something that in normal ECGs that it seems that there are subtle ECG markers or abnormalities or features that are of interest and are not being captured by traditional analysis. So it's very important to try to understand what is happening here. Finally, this is a really multidisciplinary team. I saw in previous presentations that you need to have data scientists, engineers, statistician, and clinical cardiology, and we try to do this in group. And this paper is 3 first authors, one from the cardiology, other for the electrical engineering, other for the statistician group, in a way that only if you combine the knowledge from these different fields, we can try to have some usable, some possibility in machine learning in health. We invite you when the pandemic is over to come to Brazil with beautiful landscapes and places, because we expect to host the next ECG meeting here in Belo Horizonte. We have to cancel the 2020 meeting here, but we expect to have you here for the ISE meeting next year, July next year. Thank you.
All right, thank you, Tom. Any questions? Presentation.
Understand, Bob, that maybe there is the question and answer.
Yeah. Nobody seems to have entered any yet. Monitoring both the chat and the Q&A. Oh, there's a question. Okay. Have you studied or intend to measure the heart rate dynamical parameters such as heart rate variability?
Yes, we are now in a collaboration with a group of Israel, and we are getting some additional features from this sample, and we will try to see if they can add something, some prognostic value, some accuracy first, and then some prognostic value. When we are studying the prediction of AFib, and most of the information comes from the DNN. It's really impressive that it seems that it gets the information from the other risk factors, and so if you do the DNN, most of the information is there. It's somehow funny. I know that it's much easier when you have like 100 photos or something that you can understand what are influencing your result. But I can say that we unfortunately the DNN seems to be more efficient for most cases.
Okay. Next question is about the saliency figure at the end of toward the end of the talk. That was the one that had the frequency spectrum. The comment is, it seems that the P wave plays an important role.
Yes, it was a big surprise. I'm a cardiologist that I always try to find some high frequency components of the QRS or the repolarization that could be important. And so we are very, very surprised when you got from both sources, both of these maps that the engineer did, and that's showing that the region that's more sensitive, information is more sensitive, is relatively low frequency. And when you go to the salience map, they are mostly the same, and we show them to the cardiologists, and a lot of P waves, a lot of T waves, a lot of baseline, and they cannot understand why. It's sometimes the heat maps that you have in image when you use AI in image, they are much easier to interpret than this kind of saliency maps for ECG. So how to interpret, how to try to understand what's happening when you use AI in ECG is really not easy to tackle, a question not easy to answer. So we are impressed that P waves are so important, not our expectation. If I have to guess something, I will say, oh, there is some kind of high frequency component inside the QRS that would be the most important one, but that's not what we found.
Okay, thank you. Interesting question. Did you look at ECG sex prediction opposed to ECG-Age, prognostic value?
Taki, Atia, and Francisco, and the people from Mayo Clinic, we are working together in something in Chagas disease. They did this, and they got a very excellent, very good result. So we didn't, since we understand that we could not add too much. In the beginning we did, and we got very good results indeed, not very different from them. But we understood that the gap of knowledge by this time was how to use the ECG, the age gap between the ECG and the chronological age in the clinical practice. And we understand that maybe this is more useful to have only the information that the ECG can give information about the risk of death. Because if you have this, it's easy to understand to the medical doctor, to the patient, and uses this concept that we have of biological age, that it's something very established in cardiovascular disease. And we did some preliminary studies trying to reclassify, to do the reclassification of risk. So people that that have the intermediate risk of death, considering the current score, the Framingham heart study score, and the others, and using the ECG to redefine the risk as high or low, like we do now with coronary calcium. And but it's much cheaper, much lower cost, and much easier to do. So we understand that there is a role in primary health care in deciding, maybe in deciding who will receive statins or more intensive preventive care. if we can prove that this prognostic value is of clinical importance.
Okay. Joel Shu is asking, for the interoperable part, what method is used to find low amplitude portion of ECGs contributed more?
I didn't understand, Bob.
For the interoperable part, I'm not sure what that referred to. What method is used to find low amplitude portion of ECGs contributed?
Oh, I will be in depth with you. I know that they have some kind of the transformation and this kind of modification of this part of the spectrum, but I really do not know how it's done. I can try to check inside the paper. There is something, and it's too much for a clinical cardiologist, I can say. Sorry for this.
All right, and we'll just move on to the last question here. It's a comment, I guess. Part of the low frequency information used by the DNN could actually just be the RR interval.
Yes, of course. I think so. I think it's something very important. We have some studies, and I showed to Peter because it uses heart rate is extremely powerful prognostic marker in this sample. So if the heart rate is over 70 and 80, the risk of death began to increase very, very steeply. So it's really, I think that there are some information in the heart rate, of course.
Okay. Great. Okay. Yep. So thank you, Tom. Thank you, everybody, for your questions. We will stop this and hang with us momentarily, and we'll start the next talk. Thank you.
Thank you for always staying in the audience.